Again, like Dr. Naufal already has mentioned, this is going to be everything from the basics. So if you have just joined orthopedics, this is going to be quite well for you. However, if you have not seen much of pediatric orthopedics, then also this is going to be quite informative for you. So with that, let's start off. So this particular topic I'm going to be discussing today is going to be on developmental dysplasia of hip, which is also known as DDH. It is one of the most commonly treated conditions in pediatric orthopedics, and it is also quite a challenging condition to treat because it is a spectrum of disorders. So without delaying, let's first delve into what the definition is going to be. So DDH is a spectrum of disorders. It's a spectrum of disorders of the development of the hip that presents in different forms at different ages. So a few things that you need to keep in mind here is that it is not one single condition. It is a spectrum of disorders. So a completely dislocated hip can be a DDH, a subluxatable hip can be a DDH, a dysplastic hip, which is presenting in adolescence, can be a DDH, and also a very late presenting DDH can be seen in adults as well. So it's a spectrum of different conditions, and they present in different forms at different ages. The basic etiology is the excessive laxity of the hip capsule, which leads to a failure to maintain the femoral head within the acetabulum. That is, the femoral head, the ball joint, is not able to sit within the socket. So this is because of the excessive laxity of the hip capsule. Now, this is a very basic idea of what DDH etiology is. Now, we know that DDH is a disorder that evolves over time. It is very different in a fetus. It can be present pre-birth. It can be present in an infant. It can be present in a toddler. It can be present in school-going children, in children who are walking around in the playground, and also in adults. So it's a disorder that evolves over time. A subluxatable hip in an infant can lead to a dysplastic hip when the child is going to school, and lead to a painful and degenerative hip joint when the child is an adolescent or an adult. So this DDH is a disorder that evolves over time. Now, we call DDH as idiopathic when we cannot find out a cause for the DDH. And an idiopathic DDH is the most common type of DDH. Now, in the idiopathic variety, we have a dislocated DDH where there is no articular congruity or there is no articular connection between the femoral head and the acetabulum. In a dislocated DDH, the Shenton's line is going to be broken. Next, we come to a subluxation of the joint. This is also in the spectrum of an idiopathic DDH. In a subluxated DDH, the articular surface are in contact with each other, but they are not in complete contact. That means there is a partial dislocation of the joint, and that partial dislocation is known as a subluxation. Now, in a subluxation as well, there is going to be a broken Shenton line, and the center edge angle of Weberg is going to be increased, is going to be decreased. So these are the things that you need to keep in mind. If you do not know what a center edge angle is, we will come to that in a future slides. And lastly, a dysplastic acetabulum. Now, in a dysplastic acetabulum, the contact between the femoral head and the acetabulum is going to be normal. However, the acetabular slope, the Sharp's angle, is going to be increased, and that leads to a progressive subluxation of the hip joint, which can lead to a dislocation. So in this image on top, we have a dysplastic hip with the acetabulum, which is shallow. We have a subluxated hip joint, and we have a completely dislocated hip joint. So those are the three types of idiopathic varieties. Next, we have the teratologic variety. In the teratologic variety, the dislocation is commonly seen or is commonly present before birth. The dislocation is not reducible on examination of the neonatal hip, and the range of motion is going to be limited. Most teratological hips have a known cause, such as an arthrogrypotic hip, a dislocated hip secondary to hip contractures, a neuromuscular problem leading to a DDH, or a DDH which is syndromic. All of these can lead to a teratologic hip. Most commonly, arthrogrypotic and spinal dysraphisms lead to a teratologic hip, such as myelomeningocele, sacral agenesis, or a spina bifida can lead to a teratological hip. So these are the common causes of teratologic hips. So this is your basic classification of DDH. So if you see a child with DDH, and this is the first time you're examining, then of course all of you know about the Ortolani's and Barlow sign. If they are not able, you're not able to get them, both the Ortolani's and Barlow's, then one of the things that you are supposed to keep in mind is a teratological hip, especially in cases where the range of motion of not just the hip, but also the knee and ankle are reduced. Now coming to the incidence of DDH. A pure dislocation where there is no articular congruity between the femoral head and the acetabulum, such dislocations have an incidence of 1.4 per 1,000 births. However, clinical findings, that means having the Ortolani's and Barlow's positive or an ultrasound abnormality, that which can be found out with the graph classification, the incidence is much more common. It is 2.3 per 100 births. So if you see, you have to compare the 1,000 births here versus per 100 births here. So it is much more commoner to have a subluxatable hip or a dislocatable hip, which eventually leads on to a full-fledged dislocation or a acetabular dysplasia. That is why a clinical finding and an ultrasound finding are very, very sharp to detect the presence of a DDH. Okay. Now, again, you might ask, why is the incidence so high? There are a couple of reasons. Now, clinical findings and ultrasound abnormalities are going to be seen only in high-risk children. Who are these high-risk children? Firstborn females with a breech presentation and family history. So these are the 4 high-risk categories. That is, firstborn female with a breech presentation and a family history of DDH. So these 4 conditions will make those children a high-risk children, and all of them are generally examined both clinically and with the help of ultrasound to find out for DDH. And since all of these children are undergoing the clinical examination and ultrasound findings, you are more bound to have the presence of an abnormal finding in these high-risk children. Whereas a dislocation is only found out in a later point of time, and that is why the incidence of a dislocation appears to be lower, okay, than a subluxation. I hope I am clear here. Now let's come to the etiology. Now the etiology of developmental dysplasia of hip can be divided into ligamentous laxity, into prenatal factors, into postnatal factors, and into primary acetabular dysplasia, out of which the 3 in the middle, that is the ligamentous laxity, the prenatal factors, and the postnatal factors, are more commonly associated to be causing DDH than a primary acetabular dysplasia. Now let's discuss these one by one, and this is going to be the crux of our understanding of DDH for this particular session. Now coming to ligamentous laxity, we know that there is a certain hormone known as the relaxin hormone, which is present in the gravid mother during childbirth. And this relaxin hormone is able to cross the placental barrier and reach the fetus. Now the relaxin hormone may reach the fetus. However, The receptors for the relaxin hormone